Okay, so thank you, and I'm going to actually welcome our panelists up here and introduce them in a second. I'm Stanley Brown, and I have the very, very small task of moderating a whole bunch of really smart, talented people who actually have the challenge for today, which is to talk about simple things like the priorities, the sustainability, and actually the vision for patient-oriented research in Ontario, and I hope we'll go more broadly and talk about the country as well. So with that, I'd actually welcome all the panelists up as they get mic'd. And I'm going to just introduce the first, actually I'll introduce all the panelists as they get mic'd. But first, Nancy Lefebre, who's here with me. Nancy is the Chief Clinical Executive and a Vice President at St. Elizabeth's Healthcare. But I think probably better to say you're kind of the driving force behind the innovation and a lot of the leadership that St. Elizabeth's is showing, not just as an organization, but within the system right now. Very shortly, we're going to have Andreas Laupacis come up as well. I think I get to do this introduction every once in a while with people. I'm sure everyone knows Andreas, and if you don't, that's your problem, not his. He's the executive director at Li Ka-shing, but I think more importantly, he's someone who's always combined clinical practice with research and with leadership, and someone who's actually brought something new several times to his career, shifting focus from things like cost effectiveness and technology evaluation through to patient engagement. And he actually holds a Canada Research Chair in patient engagement right now. Very shortly as well, we're going to have Brian Clark up on stage. Brian is with Patients Canada as an advisor right now, and in that role has worked with local health integration networks, with a variety of different organizations. But he's someone who brings, I think, a very strong, practical sort of business bent to the whole question as well, having worked with companies like Unisys and Jade, which a number of you have heard about for years. And just coming up now is Dr. Roger Strasser. So Roger is someone, again, who has published on this whole theme of community engagement, and someone who had a leadership role at Monash in well south of here, where it's not summer right now, but also has helped, has actually led the creation of our first new medical school in 35 years in this province, but notably not only a new medical school, but a very different type of medical school as well up in the Northern Ontario School of Medicine. With that, I'm going to be diligent about keeping everyone to 7 to 8 minutes of comments. I'm up here in part because I think I'm the largest person in health policy, so I can enforce a little bit of discipline on the proceedings. And then I've got to try to synthesize what everyone has said. I'll throw it out for discussion and hopefully get us all engaged in this question of what, well, where do we go from here? Brian, last up and first up. Okay, can I turn over to you first off, please?
So I think we're talking about SPOR 2, and in SPOR 2, I think we'll recognise healthcare professionals as the disease experts and patients as the living with the disease experts. So if research project has a big component of living with disease, obviously patients will be co-principal investigators or principal investigators for those projects. And in the world of chronic disease that we live in, obviously this is accentuated dramatically with living with disease being a major component. The other thing that's been mentioned at this conference is that patients are no longer a free good. So patients will be remunerated for their work in project research teams. With the ongoing development of PROMs and PREMs and getting patient feedback, we will see patient health goals reflected, and as we also commented at this conference, patient importance outcomes rather than patient-reported outcomes. The other thing that will happen in SPOR 2 is a dramatic effect of technology. Wearable technology is already having a major effect in increasing shifting the power to the patient, where the patient will be in control of the data and the patient will have the data, and that will have a big effect on research as well. I know on the first day of the iWatch released by Apple, 11,000 people signed up to voluntarily provide their vital signs data into a real-time cloud. The other part about technology is smartphone apps that enable research teams to quickly enroll patients into research projects. Stanford University cardiovascular study recruited 11,000 volunteers in one day. And a Parkinson's study enrolled over 7,000 in 6 hours, and that's dramatically faster than we're certainly used to. So this shift in terms of technology and putting the data with the patients, and where the data flows, so does the power. So the patient will become a much more prominent part of the system, obviously. And as has happened in other industries, that wearable technology, that cell phone technology, will end run the big EMR databases in the corporate sector. So the database, the IT departments in the hospitals, etc., will also have to grapple with that dramatic shift. The last comment I'd have about SPOR 2 is in the area of knowledge transfer. As we see in the vaccination area, the science community does a very poor job of marketing. And right now, the anti-vaxxers are winning. And the research community also needs to be employing marketing people to sell to the public the benefits of this research and the benefits of the research that's been conducted in the Canadian marketplace. And a marketing capability that can rephrase the acronyms and rephrase the complex terminology to really educate the public as to what the research community does in terms of advancing the quality of life. Thank you.
Andreas, maybe I could turn it to you now.
Thanks, Danny. Good afternoon, everybody. It's sort of hard to see out there through the bright light. So I have spent the last 2 days with a number of patients with chronic kidney disease, some of them on dialysis, some of them not, a small number of policymakers and some researchers, working through the research priorities for a large national network that's planning to apply to the National SPOR Network Program. And my remarks are actually going to sort of reflect some of my experiences. So yesterday, we used a process developed by the James Lind Alliance in the UK that brings together patients, caregivers, and researchers, and clinicians. And clinicians, I mean nurses, physios, as well as docs, to together come up with their top 10 research. Yesterday was what are the top 10 research priorities of people with chronic kidney disease who aren't on dialysis. 2 years ago, I had the pleasure to do that for people on dialysis. And I guess if one of my Vadis, I had to look that up. Well, it's not on Wikipedia. It means what next or whatever. It's a little fancy for me. In the future would be that actually 5 years from now, we're no longer talking about, and actually I think that's already happening that we're not, but we're not talking about patients meeting together, researchers meeting together, but that we do it together right from the beginning. And I'll give you a couple of examples where how I think having patients and researchers in the same room is just so powerful. So 2 years ago, there was a woman on dialysis, and I honestly can't remember her symptom, but she passionately talked about how important this symptom that was uncontrolled for her was, and how she really wanted research to improve that. And then she spontaneously turned to the kidney doctor beside her and said, you know, we're here, though, to figure out what the research priorities are for all people on dialysis. And you see a lot more people than me. So if you tell me that what I'm telling you is really rare and you don't see it in your practice, it shouldn't be in the top 10. But if you say it's common, then I've just told everybody in this room, in terms of the comment that was just made, what it's like to live with that symptom. So I thought that was an incredibly powerful moment of clinicians and patients interacting together. And yesterday, we started with 30 potential top research priorities, and we had to, by the end of the day, narrow it down to 10. And it was actually a nephrologist from Manitoba who spoke, and we start by sort of saying to each person, can you tell us what your top 3 are and what your bottom 3 are out of the 30? And a number of the patients actually, one of them was, how can we redesign the system so patients who live in rural, isolated communities actually have access to high-quality kidney disease? And a bunch of the patients actually ranked that as their bottom 3. And the nephrologist had ranked it as her top 1. Because she said, I work in Manitoba, in Winnipeg. I see lots of patients from rural areas, and I can tell you the quality of care they get in terms of their kidney disease is terrible. And to make a long story short, throughout the day, watching that interaction between practitioners and patients, it turned out that one raised in the thing to be number 10. But the point was that it's that synergy that I think is so incredibly powerful. And actually, by the way, we had done a bad job of inviting not all the patients that we invited there should have been there and were great, but none of them actually came from rural and isolated communities. And so that was a really important thing. If I had to say, what's the one thing that I worry about, and certainly the work I've done with engaging patients in research priority setting, is we've done quite a poor job of identifying and engaging the frail elderly and people in disadvantaged populations. And I just think that's, if I had to say what's the number 1 research priority and focus in that area, for me, that would be it. We really gotta, and actually to understand, are there priorities different than those that aren't like those folks? Final couple of comments. I do think we need to evaluate sort of how we're doing this, the different ways of doing it. And actually, yesterday's meeting was part of a randomized trial where actually twice as many patients and twice as many clinicians were randomized to either having that priority setting process done through a wiki or through the face-to-face meeting to actually see what kind of difference it made. And so I think that's important. And then the final thing is as we engage patients, how do we make sure that the patients who have sort of relatively rare diseases don't get lost? And I'm not saying they necessarily will, but yesterday's meeting I observed that one of the criteria that a lot of people were using, well, how common is this? And so that means that people that have very uncommon diseases aren't going to have their disorders researched. Having said that, about 3 months ago was involved in a priority setting process for renal cancer. And actually, the number 1 priority that came through that was research in a really rare type of renal cancer, because that was felt to be important. So that's not always a problem, but something I think we need to keep an eye on. So my quo vadis, more and more involvement of patients, caregivers, clinicians together, and keeping a very close eye, or actually proactively involving frail folks and disadvantaged folks. Thank you.
Thank you. Nancy?
Thank you. Well, good afternoon. It's a pleasure to be here. And I think it's a very timely topic that we're discussing today, given the focus with person and family-centered care within the healthcare, as we heard Leslie talk about, that it's not surprising that we're looking at the same issues as it relates to research. And I was also glad to hear the last presentation talk about it being actually a journey and we're on baby steps, because I think the future of patient-oriented research is a real stretch goal for us, as we say at St. Elizabeth, and one that's achievable, but the closer you get to it, the further away it sometimes seems. So we have been on our own journey at St. Elizabeth in relation to patient-oriented research, and so I thought I'd share a little bit of our experience, our stories in terms of on-the-ground applied health services research, what that looks like, what are the keys to enable the success, and what do we need to sustain things from a future perspective. And I guess you can really depict our journey if I look back over the last 10 years in the establishment of our research center and where we've been going. We really started at one end of the spectrum, which was, yes, maybe sometimes involving patients in something or another that looked like research, to more of a participatory type of research, where we involve them in focus groups and perhaps reviewing our final report, to a more patient-engaged process, which is similar to what you're speaking about, which is where we're at now. And I think the future is to begin to look at the other end of the spectrum, which is the patient-driven research. And so in the early days, we used to begin by determining our research questions ourselves in our own environment. We'd take a look at the literature, we'd undertake the design the methodology. Maybe we'd bring patients in for participating in focus groups and responding to stakeholder interviews. Then we'd pull our findings together, do a report, and maybe we'd bring patients back in, or we'd send the report out to them for feedback. But when I reflect on that, probably we're just looking for their blessing so that we could move forward and present and publish it. And I think what we've learned over the last few years is that that approach, while it did generate new knowledge and suggested that more research needed to be done, what it didn't do was yield any type of uptake, and as a result, very little impact. So as an organization that's a social community enterprise that continues to invest in research, we had to stop ourselves and take a look at what were we doing, and not surprisingly, we started to look at where are we starting, because we have a philosophy in our organization that says, where you begin and where you start something will predict where you will end up. If you transform the health system from looking at a patient in a bed, you're going to get one system. If you look at a citizen in a home environment and you transform the system with their network of supports and resources, you'll get something else. So if we look at applying that same concept to research and patient-oriented research, which is what we did, we started at a very different point, and that was beginning with the patient. And we went where the patients were, and where they existed and where the knowledge existed. So we went out into their homes, and we do have a unique opportunity working in the home care environment because it is a bit of a window to their lives, to what's important to them, and the context becomes so much more important than the illness, the disease, or the treatment. It's really about the context within which they live that also then helps you understand what is important to the patient. And the patient is also much broader than just an individual citizen. There are people that are surrounded with family, friends, neighbors, and in the First Nations and Inuit Métis work that we do from a research perspective, it's even broader than that. It's about community. So we needed to look at things in a very different way and begin to spread our research and approach our research in a different way. So a really great example that I wanted to share with you is around our caregiver research, where we were given some funding to take a look at best practices for caregiver support programs, both education and support, and what would that look like. So instead of kind of moving off on our own, we engaged a number of patients and their caregivers to help us further refine the question. We undertook the literature review, reviewed the information with them. They were part of the step of the process and the research journey right through in terms of designing the methodology and even the way we went about undertaking our focus groups. So with our focus groups, we actually went out to people's homes. So we had a research team that went out to the individual homes. So talk about bringing researchers and decision makers together. We went out to their homes individually across the province and then connected everybody virtually through the use of technology to host a focus group. And what we found is that because patients and caregivers were in their own environment where they were in control and we were guests in their home, that the information and the results and the findings that we obtained from that interaction were far more substantial than what we would have traditionally obtained. So when we also use then the next step in terms of analyzing the findings and the results with our patients and caregivers, they didn't want to stop at just the fact that we got some results, we created new knowledge, we're going to publish it and present it. They wanted to translate that information into something that would be useful for the broader community and the healthcare system at large to really understand what a good caregiver support program and education would look like. So they forced us to create tools. They had us create a self-assessment tool that organizations could use to assess where they are at in terms of benchmarking against best practices. They evolved our best practices that were derived from the literature from 5 to 20 indicators, and they insisted that we put all of that information up on the website so that other organizations could seek that out and to be accessing it. So because of that, we had a much different output and result than we would have initially. Now we're moving on to looking at patient-driven research. And in patient-driven research, we started to do some work with a group called PACER. You might be familiar with them. It's a group from the University of Calgary. But there was a group of caregivers that wanted to participate or lead their own research as part of this group, where they give them education to develop their own skills in terms of leading research. And they were looking for a sponsor organization. They looked everywhere, supposedly, they looked high and low to find somebody that would work with them, because in this approach, researchers become guides at the side versus actually leading it. And it's the individual groups that create the questions that they want to research. They're taught how to do the methodology, and you are in a supporting kind of role. So we've just begun to venture down that path, and I think it's pretty darn exciting. But does it ever turn everything upside down compared to what we're used to from a very traditional perspective? And so I think that we're going to be learning a lot from them, but one of the things that's clear to me is that as a result of that project is that we need, as researchers, we need new skills. We need to be educated how to work in their context and in their environment versus traditionally we teach patients and caregivers how to work within our environment. So in summary, just a few things in terms of patient-oriented research and the future of it. I think there's probably 6 things that I think that are going to be imperative for moving forward and for sustainability. One is that we need to understand that it is an iterative process. It's not a direct line from A to B. It's an iterative process. It's like creating a spiral of learning. It is, in order for it to be realized, patients must be involved every step of the way, and in some cases leading it in many cases, and that this type of research is very, very messy, and it's very time consuming. And it forces us to do things in a completely different way. I think last of all, we have to be prepared to go to the patient's environment and to be educated. I think we need to figure out as a system what incentives we're going to be giving to those things. And I heard John Lavis mention that in terms of the incentives and also the funding. And lastly, I think we need to be prepared to give up control, and that's going to be the most difficult thing that I think we're going to have to do.
Thanks, Nancy. Roger.
Yes, well, thanks. I suspect what I'm going to say in some ways will connect with what's been said, and in other ways will seem quite different. At first, when you said that the health professionals are disease, I thought you were saying the health professionals are the disease. Then you added the word expert, and I thought, no, that's not quite right. I certainly want to pick up on the idea of starting in a different place. My themes for this projection into the future are social accountability and community engagement. And I want to share with you experience from Northern Ontario School of Medicine. The way that I help people to understand how we developed the model we have in Northern Ontario for Northern Ontario School of Medicine is about starting in a different place. So it's about the story of the traveller in the countryside in Ireland who wants to get to Dublin. So he's in the countryside in Ireland, he wants to get to Dublin. He doesn't know how to get there, and he sees a farmer in the field. So he goes up to the farmer and he says to the farmer, "How do I get to Dublin from here?" And the farmer stops and he looks into the distance and he thinks for a minute and he looks back at the traveller and says, "If you want to get to Dublin, I wouldn't start from here." So the point of this is that as we developed the model for Northern Ontario School of Medicine, we didn't take an off-the-shelf version of a medical school and somehow try to transform it or transplant it into Northern Ontario. We started in Northern Ontario and we drew on research evidence and experience from medical schools around the world to develop our own model for Northern Ontario School of Medicine. The genesis of the school was a widespread community movement which said if we're ever going to turn around the chronic shortage of doctors and other health professionals in Northern Ontario, if we're ever going to improve the health of the people of Northern Ontario, we need our own Northern Ontario School of Medicine. So the school really began with a social accountability mandate. That's a commitment to be responsive to the needs of the people and communities of Northern Ontario with a focus on improving the health of the people of Northern Ontario. And that social accountability mandate really drives everything that we do in Northern Ontario School of Medicine. And that means that all of our education, research and service activities are about improving the health of the people of Northern Ontario. We've developed what we call distributed community engaged learning as our distinctive model for medical education and health research. Distributed means that we have multiple locations, actually over 90 different sites in Northern Ontario where our students, our residents, our other learners may undertake part of their clinical learning, where we have faculty members, where we have research. In fact, we see the entire geography of Northern Ontario as the campus of the Northern Ontario School of Medicine. so we're distributed. We rely heavily on electronic communications to connect the sites, both in real time synchronously and asynchronously. We have an extensive digital library service, and so in a sense, for our learners, our faculty members, our community members, if they have access to the internet, they have access to educational resources and information pretty much the same as if they're in the big city in a teaching hospital environment. But the centrepiece really of the school is community engagement. That's interdependent partnerships with the communities of Northern Ontario, and so that the communities are very much involved right from the beginning, very much involved in developing the model and the activities, the education and research activities of Northern Ontario School of Medicine. We have 3 populations of special interest, remote and rural communities, and we've established in the rural communities what we call local NOSM groups. NOSM, Northern Ontario School of Medicine, local NOSM groups. And these are kind of like a steering committee for the school in the community. It's a mechanism by which the community is a part of the school and the school is a part of the community. And the membership of the local NOSM group are people in the community, civic leaders, like from local government. The mayor is often a member of the local NOSM group. Leaders in the hospital healthcare sector, if we have a post-secondary education institution, they're part of the local NOSM group, as well as, of course, the health professionals, doctors and other health professionals who are faculty members in that community. So the local NOSM group is a mechanism for community engagement, and that the communities are helping in the development and delivery of the programs of Northern Ontario School of Medicine. We have 2 other populations of special interest, Aboriginal and Francophone, and in both cases we've developed a mechanism of seeking input from the people in the communities. The Francophones, every about 3 years, we have what we call a Francophone Symposium, where people from across Northern Ontario come together. We report to them the activities of the school in terms of the Francophone dimension, and they provide us with recommendations and guidance for what we should be doing to take the school further. And we have a Francophone reference group that then provides, it's an advisory committee to me, directly to me as the Dean, to keep us focused on the Francophone dimension. And similarly for Aboriginal people. In fact, the first public event of Northern Ontario School of Medicine was a curriculum workshop that we held in Sault Ste. Marie in January of 2003. It was held in Sault Ste. Marie deliberately to signal that we really would be a school for the whole of Northern Ontario, not just a Sudbury or a Thunder Bay medical school. And we invited everybody who had an interest in being involved in developing the Northern Ontario dimension to the medical school. And we thought if we had 200 people coming, we'd be doing well. We had actually over 500 expressions of interest, but we could only hold 300 in the venue in Sault Ste. Marie. So we had about 100 physicians, 80 academics, 50 Aboriginal people, 50 Francophones, people from small communities, large communities, local government, well represented. And we spent 3 days mostly in smaller groups discussing the issues. And it became clear to me, if we're ever going to really understand what the Aboriginal people were looking for from their medical school in Northern Ontario, we need to have a separate Aboriginal workshop. So we did that just a few months later in June of 2003. This was held in a First Nation just near Kenora. And then we asked the Aboriginal people to give us direction. And so that we referred to as the Follow Your Dreams workshop, and the direction, the recommendations from that workshop really provided the framework for the development of the Aboriginal dimension to the school. And we have an Aboriginal reference group that provides recommendations between time. There was a point at which we realised that as we were wanting to focus more on research and undertaking research with Aboriginal people, that we needed to actually focus on research. And so in November of 2008, we held a Partnership Opportunities in Research gathering, where again, it was about 100 Aboriginal people from across Northern Ontario. We had academics, researchers from the school and our universities, also from this part of the province as well. David Henry was there. I'm not sure if he's still here. Yeah. And we spent 3 days in large circles, small circles, because I mean it's the ultimate culture clash, really. You know, the worldview of academic researchers and the worldview of people, Aboriginal peoples. And so through those interactions, we developed some common ground, and because, of course, everyone wants to be involved in helping improve the health of the Aboriginal people. And so we found that that's been a very powerful mechanism, really, for developing collaborations and partnerships and towards research to make a difference, to improve the health of the people. So my co-Vadis, the future really that I see of patient-oriented research is where people in communities develop the research questions and drive the research projects in the community, for the community, to improve the health of the community.
Great, thank you. So look, just as the first bit, I'm going to try now to play back a little bit what I've heard. And I'm obviously putting myself in a vulnerable position when I do this. But I want to see if I can organize the diversity of comments we've had and talk about 3 significant themes on where we go. And then I'm going to turn it back to the panel to hopefully tear them apart a little bit and get us to the next thing. So the first thing I'm going to suggest is that we're actually probably right in the thick of a transformation. And I'll lay out what I see as a sort of transformation in starting with a personal story. So 20 years ago, my father was a neurologist and actually a pharmacologist as well. Did something for a dean somewhere, and it was punishing enough that he got a little reward at the end, and the reward was to be able to go to an institute on patient engagement and experience. And he thought this was a really, really good idea. And most of his colleagues said, why are you doing that? And so I think we've moved from a place perhaps 20 years ago to a place maybe 5 years ago where it wasn't odd anymore, but it was intrinsically good. It made sense to do something with patients, and we could kind of accept that as a thing in itself. Now I think we're seeing it as something instrumental, something we'd actually pay for. Brian, to use kind of what you're talking about, right? It actually creates greater value. As I think about that, that requires us now to think about very different structures of research teams. You know, the old joke was interdisciplinary work was a gynecologist and an obstetrician working together, or people who work on similar but really not very distinct questions. Now it's gone beyond the way we used to think about interdisciplinary to a team that actually engages people very fully. The second thing I'd say perhaps here is that I'm going to maybe just start with actually change gears for a sec. There's a paper years ago in the Journal of the American Medical Association called What Makes People Patients and Patients People? And it was a very thoughtful discussion of what that boundary line is. And in fact, as I'm listening here, I see the clarity around that boundary line blurring again. And so talking about one of these profound transformations where people throw off data all the time now, the digital devices and the wearable technology. When we talk about patient, what we're really talking about, and Roger, you talk about this as well, is giving voice to all the people who typically don't have voice in these. And Andreas, you talked about the need to make sure that we deal with groups who are already marginalized and may not get voice anyways, and context is important in this. And so I'd argue that this is a major transformation, but we actually have no idea what the policy framework is around this. This is information. These are issues about privacy, but people are sharing it, and we're completely unready for it. But we're also not probably sure who we're dealing with anymore. It's a very variable group that changes, and there's a need to engage across that changing. I'd also say that, and I'm going to channel perhaps Roger here, but also some of the things John Lavis said in the last panel, this isn't just about patient engagement in research. This is about patient engagement in knowledge transfer as well. And I'm not sure that that full part of the value chain has been connected here. So the lines are perhaps a little more blurred, and maybe that's a good thing. The third thing that I sort of note here is that we're kind of in a period of foment and forming of a research field. I think the worst and most frightening thing you can say to someone who's methodologically rigorous is that it's messy, right? It's not supposed to be messy. There's a personality type that gets drawn into research, and it's not the type that likes to leave a whole bunch of things kind of undone. That's how experiments go bad. So I guess the thing is, one of our big challenges is to make this less messy. And perhaps the way that we do that, and this is a fundamental sort of reframing, and Roger, you use the A word, okay, is that it becomes part of accountability. And so, we have codes in just about every profession. We don't necessarily have codes as researchers. And so perhaps this becomes part of the social accountability of our various disciplines, that you must have patients engaged in these new ways. And we can move, I think, perhaps away from the questions that we've probably been focused on in patient-oriented research around the what is patient-oriented research, or the why we should have patient-oriented research, to I think perhaps the much more practical and compelling questions around how and where, which I think is a critical question, and also the when. The thing I'll leave off with here, and I don't have necessarily a place to put this in an easy bucket, maybe it goes into bucket 2, is this issue of how we communicate evidence more generally. And Brian, you made this sort of terrifying point that the anti-vaxxers are winning, right? Well, thankfully in Canada we're a little okay. Our Minister of Health at least stood up and said people should get vaccinated, which was a good thing. But the point is, how do we communicate evidence in the way that we're comfortable communicating it, but still that it becomes compelling and a useful tool to people as we go along? Because I think, we spent a long time thinking about how to communicate elegantly, but not to overstate anything, right? The kiss of death when you submit a paper is to overstate your recommendations or overstate your claims. But that puts you at an immediate vulnerability or weakness to anyone who's willing to overstate their arguments, particularly when it's not sort of contested on the pages of a journal. So with that, I'll stop there and just sort of summarize that we now need to work on this as something instrumental. In fact, probably moving to questions about the how and the where and the when will make this a much more useful thing within research, and we can probably study patient-oriented research from that side. I'd suggest that we probably start to look at people as perhaps the unit of engagement that we need here, because people will be throwing off health information well beyond when they're a patient. And we need to figure out what that actually looks like and how we treat that with respect, but also treat it as an asset that can be built on. And finally, that we need to probably tidy up the field a little bit and perhaps move it into something that shouldn't at least feel messy. It should be part of the expectation and part of the accountability. Is that a reasonable quo vadis? The closing remarks are here now, so I mean, we could close off there. Nancy, something to add?
Well, I think I was just going to say, I don't think it's such a bad thing that it's messy, and I know that strikes terror into researchers' hearts, but I mean, I think that there's things that you can do to maintain the rigor of the methodology and come out with something that's good evidentiary information. You just have to know that when you're dealing with people and relationships, that it is not a defined A to B kind of process. It is not linear. It's not, you've ever done research with First Nations, Inuit, and Métis communities, it's, there's the diversity, there's the culture, there's the complexity. So I think it's okay.
So you used a word there that's actually challenging a lot, which is relationships, right? Mm-hmm. And that's not something you ever get trained in, right? So I trained in public health, learned some statistics, learned some experimental design, and I've learned about relationships mostly through failures in them. So, this is a whole area of how one engages that I don't think actually we've done much on, so I want to draw that out to assignments.
Well, it's a good point, and we've just are embarking on a 3-year study, again, with First Nations, Inuit, Métis communities, and our first year is all about relationships, is building those relationships of trust, culturally safe, appropriate, defining the methodology and the design of the study, an entire year, and I think that's something that we need to look at too, is, are we prepared to make that kind of investment from a time perspective that it's actually going to take, and is the funding going to follow that as well to enable that?
Okay, good, thank you. Andreas, something to add?
So you said so many things, Stanley, that I could respond to a number of them, and so I'll maybe just respond to one, which is your comment about, this isn't just about research, it's about involving patients more in the healthcare system, and maybe just reflect upon one experience I had recently, which just made me realize that you really can do this even with patients who have been very, very emotionally scarred by some very terrible things that have happened. So not that long ago, Minister Hoskins asked me if I would chair a panel to provide him some advice about a law that exists called the Quality of Care Information Protection Act, and there's some controversy around whether the investigation of critical incidences is open enough to patients and families. So the first thing I did was I said I'd be delighted to do that if I could co-chair it with a patient, and he readily agreed. So I co-chaired it with Angela Moran, who's a patient and family sort of advocate from Kingston. And then with the help of Peter McLeod, who runs a company called Mass LBP, we actually brought together 16 patients and families who had been affected by quality of care incidences, and some actually family members had died. And sort of said, and some had a good experience in the investigation of these, and others had had a terrible. And Peter just very, ever so skillfully said to these folks, like, what principles would you advise that this panel use to write its report? And by the end of the day, they had together come up with 6 principles that, if you look at the report that's on the ministry's website, were used verbatim by the committee. So the point is that, you know, really sort of skillful and respectful involvement of patients, even at their most vulnerable, and actually it profoundly transformed the way some of us on the committee thought, actually. That's the other point to make. Really emphasize how important it was to them to have a recourse, a second place to go if they didn't feel their issues were dealt with appropriately, et cetera. So I just sort of support you, Steny, that I think we need to do this more. It takes a lot of effort. Maybe that's one thing we didn't mention, that dialysis project I told you, it took a year. Roger's talking about starting in 2003 and still working on it. And so one's really got to be committed to it, but I think if you do it, it is where we're at.
Great, thanks. Brian.
There's been a lot of discussion at this conference about defining the patient or the public or the consumer or the person. And there's also the comment about these projects with patients can be messy. And so perhaps there's some other tools out of the commercial sector that might be relevant here. The commercial sector, when it's looking at a marketplace, does market segmentation. And maybe we should start using market segmentation on patients as well. I mean, there's patients who have chronic disease who are quite mobile by themselves, and there's some that are totally dependent on the healthcare community and other people in between. And there's also other stratifications, like some patients want to be told what to do by their doctor, and there's lots of patients that would seek a joint decision-making partnership relationship, and then there's other patients that want to be self-managing. And so these are multi-dimensional segmentation strategies that might help in tidying up some of these areas.
Okay, great.
Roger. Yeah, a couple of comments on what you said, probably still on the theme of starting in a different place. The first was about communicating information and evidence. It reminded me of Sir Michael Marmot's experience. I think most people know Michael Marmot from the Social Determinants of Health report to the World Health Organization. He also did a report. He chaired a commission for the UK government that was to do with alcohol and health, and his commission presented a whole series of recommendations, and then he observed how most of the recommendations weren't taken up and followed. And that got him thinking about the issues, and he published a paper in the British Medical Journal entitled Evidence-Based Policy or Policy-Based Evidence. And his point was that he realized that the politicians who ultimately made the decisions took into account a whole range of other types of evidence than the scientific evidence that his committee was drawing on. And I think that's important for us to be considering when we're talking about communicating information and presenting evidence, that our concept of scientific evidence is just one concept. I mean, in the court of law, there's a whole different notion of what counts as evidence. So that was my first thought about what you said. The other was about the blurring the patient-person kind of item. And it seems to me starting in a different place a bit further and the starting with people in communities concept, that we actually ought to be encouraging research that isn't actually about patients, but about avoiding becoming patients. Like, people don't want to be patients. They don't want to get sick. They don't want to be in hospital. And so research, it's actually about looking at the people who avoid breaking their hips, having heart attacks. So research that focuses on people who are not patients, and what we can learn from the way that they live their lives, that then could help the people who do find their way into becoming patients and the health system.
Thank you. Okay, I'm going to throw it out to the audience for further questions. I expect people will note that I had one part of a mandate here, which was to talk about the sustainability of patient-oriented research, which I have not so far, in part because I think we've had good evidence that this is becoming instrumentally valuable, and thus something that we might actually see part of the value creation, not something that we need to kind of prime the pump on. So, Eddie.
I mean, it'd be interesting to know what you think about whether there are either contextual factors or perverse incentives around patient-oriented research as you look into the future. Are there things that we haven't thought about in terms of what it might do to the system or what it might do to us as researchers? What are the panel's thoughts on, what are the things that we aren't thinking about? We always think about the nice positive outcomes. What are the things that we might need to worry about, that risk management that was talked about earlier?
Would come to my mind right now is actually the one that John Laupacis mentioned up here. So I was driving to play squash with one of my best buddies, who's a world-class basic researcher, and he said, "Man, it's kind of starting to drive me crazy. We reviewed a grant the other day that had the most unbelievably high-quality, world-class basic science, and there was a tendency to sort of say, well, I'm not sure we're really going to fund this because we're not quite sure what the impact of it is going to be on the healthcare system and patients." And his point was, there's a whole, even though I'm not a basic science researcher, we very rapidly discovered drugs for HIV, I think, because we knew a heck of a lot of basic science that maybe we didn't know how it impacted on patients until we really needed it. So I think that would be one of mine, although I would also say that at the chronic kidney disease research priority setting process that I was just at today, there were a large number of this has to be an interdisciplinary basic science clinic. There were a bunch of basic science researchers talking about what kind of research they could do to identify the causes of itching in people with end-stage renal disease, because 2 years ago, patients identified the management of itching as their number 3 priority. So I do think that I totally don't buy the thought that involving patient priority setting is taking away from basic science, but I do think also we just got to let the basic scientists do their thing sometimes.
Anyone else?
Just picking up a theme from the earlier session, the sort of scenario modeling, considering unintended consequences, the yes but, I think is very important in considering options, and it is about getting the balance right and recognizing that there's value in all kinds of research and a whole range of perspectives, starting in a whole range of different places.
Yeah. No, I might add in too, I think some of the points have been raised very practically around, say, segmentation and so on are important because it allows you to judge the quality of the engagement. And the concern in my mind is as we do this, if we don't have ways of understanding the quality of the work that's going on, we can't judge it as in terms of the quality of the research. Emily.
Hi, thanks. Emily Nicholas, I'm with Patients Canada, and I'm hoping to articulate this clearly, but basically I kind of want to know, with the projects that you're all talking about, maybe with the exclusion of Brian, with the projects that you've talked about, kind of where are these patients now? I think one of the key parts of SPOR that we've talked about is, in terms of sustainability, is developing this capacity or developing patients who maybe have more longevity in their involvement, that it's not just a focus group or an interview. And so I'm curious as to whether there was sort of follow-up or whether there was an initiative to keep working with these patients in a more long-term way, and what you thought about this sort of difference between something like priority setting or what should we do versus, okay, now let's do it together, or even let's do this research together now that we have the priorities. So in terms of developing sustainability and capacity of those patients. So I hope that was clear.
Great. Thanks, Emily.
So those in our environment, those that we have worked with and have participated in our studies, and again, I'll just speak to the caregiver one as a good example, have continued to participate and further evolve out. Now that we've done this, they were involved in the translation, the development of tools and resources, and the communication of those. Now that we've done that, what are the other things that we can be looking at that are of relevance and importance to them that they feel should be looked at? And in moving forward with that, have moved into the PACER movement, where in fact they're driving that research agenda and we're supporting it from a go-forward perspective.
This is really a continuous quality improvement loop kind of concept. I mentioned the first Follow Your Dreams Aboriginal workshop. That was in 2003. The next one we did in 2006. And I didn't really appreciate how important that was until we were doing it, because the experience of Aboriginal people generally was that they get drawn into something that everybody wants and put their weight behind, and they might get called on to provide some input, and then they get sort of left by the wayside. So the fact that we were calling them together and reporting back on what we'd done against what they'd recommended. It was just after our medical students, one of the recommendations in the Follow Your Dreams was that all the medical students should have an immersive experience living and learning in the Aboriginal communities. And in 2006, it was just after the first group of students had done that. So we had people from the Aboriginal communities who'd hosted our medical students came and shared their experiences. So they had something more to add, really, to the discussion and added a richness. So I think the point is that it is important that this is seen as an ongoing process. It's a relationship that's there that has to be fostered and developed on a continuing basis.
Great. Andreas?
I would agree that it's a relationship that has to be fostered on a continuous basis, but just like Brian, I think appropriately segmented patients in terms of how the disease affects them. I think the patients I've interacted around research priority setting have different views about how long and how thoroughly or how intensively they want to be involved. And, you know, one of our patients on dialysis had a transplant. That's markedly changed her views about how she wants to be involved. Our caregiver, her mom died a month into the process. That changed her views. One of the people that was there today was there at our conference 2 years ago. So I think it really varies. And as long as we're committed to involving patients, as long as they want to be involved, I think that's great. Recognizing that some are going to come once and say, you know, I've done my thing and that's all I want to do, and others are going to want to be in it for the long haul.
Great. Brian, anything to add? Great. Please.
Okay, I have another question. We've talked about sort of the need for change and how all of us need to learn and adapt, and I was wondering whether anybody knows of any more formalized education for the young researchers coming through university now in the university setting to acquaint them with the concept of patient engagement, the values of it, and what fledgling methodologies and so on we have. And do you think it's important to do that?
I'm seeing some head shaking.
Yes,
So.
yes, that's the easy answer. I'm not sure of any formalized programs, and I don't know if PACER is more focused on the individuals wanting to do research who are not researchers in a formal way, but so I'm not sure if they certainly lend to the sponsor organization. They certainly are teaching us how to work with individuals who are leading research who are not traditional researchers. But I don't know if they have a formalized program. I'm not sure if anybody else here is familiar.
I can answer that because I'm a PACER intern and I'm actually on your project, and the answer is no.
Okay, all right. Well, we're learning from you in the meantime.
Okay.
McGill University has a program under Vincent Dumas where he's using patients to train budding clinicians.
And I believe there's a curriculum that will be developed too as part of the OSSU work that will actually try to provide a bit of a public resource on this and a bit of a school on it.
Okay.
So,
Thank you.
Thank you.
Not a very good answer.
Mm-hmm. No.
Well, it shows a gap.
Yeah.
Just something, maybe it was Andreas mentioned that made me think of this. this all exists in a kind of political realm and in an economic realm. And I was thinking of I was at a session a while back where they was talking about children with developmental conditions, with brain-based conditions, and they were talking about how comparing the autism community with the FSD community, and how one community was so much more politically organized, well-connected, and well-resourced, which was the autism community. And we can think about other areas here. So I'm wondering if, if we're talking about, I'm worried about the idea that, if the impetus comes and the attention comes and so forth from particular communities, I mean, there are diseases that are associated with different populations that have different levels of power. And I'm wondering what the implications of this and how we can check some unintended inequities. I mean, the autism FASD contrast was pretty powerful to me.
Andreas, you want to talk to them?
Yeah, it's a really good question, Frank, and I don't have any really smart answer. I mean, I'm old enough to remember when the HIV crisis first came. I was working in London, Ontario, and seeing these, young men die in 6 months, and it was just awful. But they became very, I don't know the history of this, but they became very politically active, very effectively, very quickly. And I think it was partly because they were kind of young, they tended to be educated, and they kind of knew how to do that. I do worry about the voice of the, it's probably my world, but as a general internist, the frail elderly with multiple comorbidities, maybe diseases that aren't that kind of, sexy is the word I was going to use, but it's not the right word, but you know what I mean, that don't sort of grab you, and there are going to be more of us in this room that are going to be in those shoes sooner than we like to think, and how do we make sure that we really hear them? But I don't have a more articulate response, Frank, sorry.
Roger?
I think it's a real issue. The squeaky wheel gets the grease, kind of. It's very much a phenomenon of our society. I would say it's not perfect, but the approach that I'm describing in terms of community engagement and provides some sort of counterbalance, because you have a mix of people who bring different perspectives who help to say, well, yeah, the autism's a big problem with people who have it, but actually FASD is, there are more people, and so it helps to kind of balance those who make the most noise, or who are the sort of best placed to advocate with those who don't have a stake in either, and put it into perspective. And I think it's important that happens more at the local sort of community level than this be a top-down kind of decree that comes from government or whatever. Okay.
I think this has been a useful discussion. I'm going to take now a little bit of a reframing based on what I've heard of Quo Vadis, or where we go. I think it's probably important to put a little bit of framing around this. Almost everything that happens in our health system has a political element to it. We'll never get away from that. But that doesn't mean that we should let sort of perfection be the enemy of the good, because there's an awful lot that we could do. So based on that, and maybe channeling Roger's good story, but I wouldn't start from here, we've probably started the whole enterprise in the wrong place. We started by thinking about what this research looks like, but we haven't thought about the front end, we haven't thought about the back end. So an important area going forward is to think about the front end. What's the actual sort of policy and organizational and structural framework that makes this easier, that captures the assets and gets value out of them? But what is also the capacity to be able to do this? We are talking about a large population of researchers who weren't trained to do this. Some may do it intuitively, some may force and encourage themselves to learn how to do it, but this is a new move, and I don't think we should forget that. And it's not necessarily an easy or a facile sort of move. It has to be done with an intensity and a commitment that takes a lot of effort. We also really haven't thought about the back end, which is about how we make sure that all of this new type and new contextualized information actually gets made valuable through its use and through its impact. And there's challenges and there's risks on this, but I think the greatest risk is to not pay attention to how we take advantage of that as we go along. The second thing I'd say is that we've got to pay attention to the quality of the work, right? And so, as in any field, there will be good and bad elements, there will be weak and strong research, but the more that we can talk about how we judge this, the more we'll be able to start to talk about patient-oriented research in the same way that we talk about the quality or the grade of the evidence underneath a finding, as a way of actually helping us understand how much to make of it. The third thing I'd say is that there's probably a little bit of a fundamental orientation that has to start, whether it be at the start of medical school or be at the start of a research training. As we try to make sure that people are ethical researchers, they also must be people who are engaging all the communities around them. And that's probably gets to your point about social accountability, but you can teach almost anything technical, but values get drilled in right from the start. And so it's probably that element that needs to get reinforced in curricula far earlier. And maybe when we think about engaging people and patients, it's something that starts actually far away from the university campus early on in life. As we start to think about health literacy, it's probably a central element. The final thing that I'll talk to is the importance of voice. And I don't like the term about giving voice to groups because they always have voices. It's probably about making sure that we hear the right combination of voices, and there's maybe techniques like segmentation that would help here, but who do we actually need to hear from so that we don't find ourselves in a place where a prominent voice or the squeaky wheel always gets the attention, and that we actually reflect, I think, the diversity of patient experience that can be perhaps lost or papered over when we think of a patient rep or those sorts of strategies of engagement. And so with that, I think my one performance measure is to finish at 3:15, and we're there, and I won't tolerate any debate on those four things, so I can step down and claim success. Please join me in thanking our panelists.